Next up, to talk about integrating medical care and public health in Taiwan's national health insurance, please welcome your speaker, Dr. Lian Chen, Director General, National Health Insurance Administration, Ministry of Health and Welfare, Taiwan. 那接下来呢，我们掌声有请卫福部中央健康保险署陈亮瑜署长来跟我们分享的主题是台湾健保如何整合医疗照护以及公共卫生。掌声欢迎署长。
Thank you. Good afternoon, all the distinguished guests. It's my great honor to represent National Health Insurance Administration to give this talk to share our Taiwanese experiences of this system that has been running in Taiwan for 30 years. So this is the outline of my talk. I don't think I need this stage, so sorry. I'm a little bit taller compared to what people imagine. So this is the outline of my talk. I'll start to talk about the healthcare challenges. This year we have officially entered the super age society. And also the second part is I'm going to talk about how we embedded the data governance in our healthcare system. And the third one, I'm going to share a little bit experiences of how we combat and survive through SARS, COVID-19 using the National Health Insurance System. And then the expert will be my next speaker, Professor CJ Chen. He's sharing more of his experiences. During these two pandemics, he's one of the leader help us survive these pandemics. And the fourth one is the perspectives, reflection, challenges for the future. So I believe you've seen this slide before. This is the 4 challenges we've been facing when Taiwan is officially entered the super age society. So that means that 1 out of 5 individuals in Taiwan is now age 65 and above. Of course, you can imagine that have posed tremendous financial challenges to our national health insurance system. It's a single payer system. It's a mandatory insured system. Cover 99.9% of our citizens. So the age of the population changes. Of course, it will pose a threat to our financial structure. The second one will be there are rising number of chronic illness and also cancer. So far, we have 23.5 million people in Taiwan, but those who are suffering from the chronic illness is about 8.5 million people. As you can imagine, it's like 1 out of 2 individuals, adult population, will be suffering from 3 highs or COPD or asthma. Also cancer. Cancer is for the 43 successive years is the leading cause of death in Taiwan. So we will also put a lot of resources into the cancer treatment. And the third one is new technology and new treatment is always expensive. So that accelerates the growth in our medical expenditures. The fourth is the thing that we keep talking about throughout this whole symposium will be the aging population and the low birth rate that will undermine the health insurance revenue. And we do need a more sustainable financial structure to support operation of national health insurance for the next 30 years. I agree with Professor Xiao. He just mentioned about the threat this morning. And thank you for your honesty. So this graph illustrates the numbers affected by the 3 highs and also the share of the global budget. You will see, as I mentioned before, about 8.5 million people in Taiwan have chronic illnesses. About 3.2 million of them are suffering from diabetes, 5.2 million for hypertension, and 5.1 million have hyperlipidemia. So we do need to incorporate the health promotion into our treatment for 3 highs. If we look further to the health burden of in Taiwan, measured by Delhi, you will see the number 1, not surprisingly, will be cancer. It constituted about 20.26%. And the second will be the cardiovascular diseases, and the third one will be diabetes. However, if we look at the medical expenditures spent on 3 highs or 3 high related comorbidities, complications, you will see it constitute, it's about 167.6 million NT dollars. It's about 1/6 of our global budget for the national health insurance. So that is why in our presidential office, we have launched a Healthy Taiwan initiative. There's a national project called AAA project, aiming to better improve the management of chronic illnesses. The AAA refers to, the first A refers to 80% of the 3 high patients will need to be covered by our big family physician program. So far, the number will be 61. We are trying to expand the service goal up to 80%. The second A will be lifestyle intervention. As we know that all the evidence have shown that 40 to 60% of the chronic illnesses worsen or occurred because of lifestyle. So our payment system are now still mainly pay for service. So we do need to incorporate lifestyle intervention into our treatment. So starting this year, August, we start to incorporate lifestyle intervention. We ask the patient to fill in the questionnaire for their diet, their exercise, their stress management, and trying to incorporate their lifestyle management into the treatment plan with their family physician. And the third A will be the mission goal for the chronic illness AAA program. It's called 80% needs to get a fair control. So this is the platform in our National Health Insurance database. Here are 2 interfaces. The first one will be the facility management interface. Here you will see the proportion of the enrolled patients, what proportion of the enrolled patients for certain clinic or medical institutions are under fair control and their data. The second one is for the case management interface. So for example, for our diabetes patients, we have the case manager following up their condition. So for the case manager, they will be able to look at the data for their patient, and also we offer the visual aid, so you will be able to see the change and the changes over time for their biochemistry profiles of these follow-up patients. So here comes my favorite part, some from Taiwan. So people always tell me that Taiwan has AI in our name, and Taiwan has AI in our DNA. So we will launch the NHI card with the chip here in it in 2004. Taiwan produced 70% of the chips, 90% of the advanced chips in the whole world. So here we have starting from 2004, we have the National Health Insurance IC card. We have the last 6 treatment visits, your prescriptions, whether you have a catastrophic disease or not, because you can get a cheaper payment for your treatment visits. The consent for palliative care, DNR, or organ donation. That's our start, back at 2004. And later on, we launched the MediCloud in 2013. Now we have the medication, the surgical records, the vaccinations, and dental services. And I want to mention particularly the immunization. So here, you will have the vaccination data, so which is crucial to play the role in several significant pandemics, including COVID-19. So you know the proportion of your individual, your population, you have 1 dose of vaccination, 2 doses, 3 doses. So that's crucial as it's a mandatory and also single payer system. So basically that's the national data. NHIA, the MediCloud system, also plays a crucial role to save unnecessary medical expenditure and also to improve the patient security. Here you will see the duplicate examination on the left. It decreased from the 2.94 to 2.31 billion NTD after we start to launch the MediCloud system. And for the medication, it decreased from 2.41 to 0.78 billion. That's a 67% drop, not just for the safe or the unnecessary prescriptions, but more importantly, it's safer for our patients. For example, if you have duplicate sedative hypnotics, that may cause you to easily fall down or you have a respiratory suppression. So it's save money and also it's better for our patient safety. So in 2019, we also further launched the virtual IC card. We have 2004, the real IC card. Then 2019, we have the virtual one embedded in our My Health Bank is an app launched from NHIA. Here you will see the hospital will submit an access request during COVID-19 to each individual and to see that whether you will authorize me to see your data, and you say yes, and the healthcare provider will be able to gain the access in the cloud to see the medical history, the prescriptions, the allergy history for each individual, and using the telemedicine to see the patients. And we will be better prepared if the next pandemics come. And furthermore, we launched the e-prescription platform this year in the eastern coast of Taiwan. Compared to the western coast of Taiwan, the medical resources are not as abundant as the western coast. So we are using the FHIR format to increase the interoperability. And also, if you are using this e-prescription, you can use the QR code in your mobile phone and to take the medication to the drugstore nearby you. You don't need to travel all the way to visit a hospital that is very far away. And it's all more eco-friendly, and also it's easier access for each individual living in the rural areas. So here comes the total solution for the barrier-free services in the era of digital health. Here you will see you could register using the virtual IC card. Then you can see the doctor using telemedicine. Then you will use the e-prescription with the QR code in your mobile phone to see the doctor. And we have a very mature e-payment system here in Taiwan. So that will be the total solution. It will be paper-free. And you don't need to go out except for taking the medication from the drugstore nearby you. That will be launched fully, hopefully very soon in the whole Taiwan. So far it's in the eastern part of Taiwan. So that will probably be the last mile of a universal healthcare. When it comes to universal healthcare, and people talk about the success of Taiwan's national health insurance, the coverage is about 99.9%. It's high accessibility and very efficient payment system. However, we do have some urban-rural disparity. For the Taipei compared to Taitung, the lifespan disparity is about 9 years, I believe, lately. So we do need to enhance the equity through the digital health. So here you will see there's a doctor. We do have 24 hours of emergency room and the internal physician in underserved areas. However, we do not have sufficient specialists, for example, eye doctor, ENT doctor, psychiatrists in those underserved areas. How do we do this? We cover that through the telemedicine and by teleconsultation. So here you will see a doctor. He is consulting another doctor living in the city. So this is a doctor helping his patient in the Ali Mountain. So the eye doctor is using the telemedicine to help examine his eye. So National Health Insurance cover all the specialty consultations starting this August. And also we have launched an app called My Health Bank. So it's not just the case manager and the medical institutions could have the data. The patient, him or herself, could have their own data. We believe that if the patient has his or her own data, it will empower them to better manage their health. And health is each one's responsibility, not just physician's responsibility. We are shifting the dialogue from the medical paternalism to like someone is responsible for your health, and we are offering the help and the data that you need. So this is the AI-generated health education information. So based on our big data analytics from the NHIA, you will see that, for example, for diabetes, for example, you will have 6 different risk sets. For each different risk set, we will feedback you the health information that you need. If for the elderly, they will not be able to read their cell phone very clearly, we also have the audio app that could help you to read out all the information. Okay. Last but not least, we are trying to reach the goal of precision medicine. It's not just for cancer treatment, but also for chronic illness management. For example, for the payment system, we are now designing different types of payment system, not just from fee-for-service, but shifting the dialogue from pay-for-service to pay-for-value. So with 6 different kinds of risk sets, we will have different kinds of payment system depend on the comorbidities, and we call that value-based care. I feel a little bit humble to talking about this topic because CJ Chen is now sitting in the front line. But I would like to mention that national health insurance play a crucial role during SARS and also during COVID-19. Here is the app. You could see we are not just having the COVID-19 vaccination. We also have the screening records linked to the My Health Bank. So now the government will have the national data of the screening results and the vaccination results. And altogether, we will be better to think through it and make a better plan for anti-COVID or anti-any pandemics coming next. Again, I feel humble that I need to talk about hepatitis B and C, but here you will see that we have so many different programs for hepatitis. 40 years ago, the leading cause of death in Taiwan is hepatitis. Now it's out of top 10 cause of mortality in Taiwan. So we did pretty good job when it comes to hepatitis B and hepatitis C treatment. So National Taiwan Insurance, we have so many programs, and in each one of program 4 different years, we ask them to screen for HBV and HCV. And then later on, for the very expensive treatment, DAA, we start to cover it in 2017. I do know that not many other countries does not cover that very expensive treatment, but that helps us to reach the goal. So we are trying to eliminate hepatitis C by 2030, but we reached the goal 5 years earlier this year. And I believe CJ Chen, Professor Chen will talk about that later in detail. So this is the aging population. I talk about we are entering the super age society this year, but people have no clue how fast we are reaching the ultra age society. So with this speed, we will reach ultra age society by 2039. That is pretty much the situation in Japan. So we have to be well prepared for the transform of the whole healthcare system. So in a super age society, we have a lot of challenges, not just financial challenges. We also face the manpower shortage, particularly nursing manpower. It's a global issue. And also we are trying to overcome the urban-rural disparity through digital health, as I mentioned before. So one key word to summarize the future NHI roadmap, I would say the key word will be integration. Service integration, data integration, resources integration. The first integration will be service integration. Let me take one clear example. As we are now the super age society, our long-term care system has become very huge and a big burden for each family. So now we have a huge data set in the Department of Long-Term Care in the Ministry of Health and Welfare. So we are now trying to merge the medical service from the NHI and also from the service from the long-term care. In order to merge that, there are two things that we need to do. First of all, we need to integrate the data. So we want to see one individual throughout the journey, how much money that he or she needs throughout the hospital, and then how much money he or she needs when he or she is using the long-term care services supported by the government. That's rule number one. Number two is we're trying to integrate the resources inside the hospital and the resources in the community. For example, for the elderly, there are a lot of resources are in the community, it's public or private from the NGO. So we are now trying to integrate these resources from the medical service and also for the MGOs and also from other communities, and to reach the goal of PPP that could be more patient-centered, person-centered services. That would be all of my talk. Thank you all for coming, and I want to mention that I do appreciate the honest, sincere sharing from this morning. Thank you so much.
Thank you very much to Director General Lian Chen of National Health Insurance Administration, Ministry of Health and Welfare, Taiwan. 非常谢谢健保署陈良宇署长的精彩分享